my choice for that trial would be the DELIVER trial, which studied dapagliflozin in patients with heart failure and a preserved ejection fraction. Now, I want to say up front that I use SGLT2 inhibitors. I've learned to treat patients with diabetes, even though I'm a cardiologist, and change their medicines, and I really like this class of drugs. And for patients with heart failure and reduced ejection fraction, they really produce nice results. However, in DELIVER, in patients with heart failure with preserved ejection fraction, they did not reduce cardiovascular mortality. Only benefit was in heart failure hospitalizations, but heart failure hospitalizations are only a small fraction of total hospitalizations. And so I think that the benefit that they have in heart failure with preserved ejection fraction is less, and the drugs are expensive. And so the proponents of these drugs are trying to get everybody to use them in all patients with heart failure, but I think that there's much less benefit and a lower value in patients with heart failure preserved ejection fraction. So I see a lot of hype in the interpretation of DELIVER trial. I really want everybody to know about the CAPLA trial. The CAPLA trial wasn't a hotline, it was a late-breaking trial, and it was in my area of atrial fibrillation, and it was a specific area of AFib ablation, but that's not the important thing in CAPLA. So this trial looked at standard pulmonary vein isolation, which is the standard we do for all patients with AFib and AFib ablation, versus pulmonary vein ablation plus posterior wall ablation, which is more work, a little bit more hazard for the patient. And everybody has believed that adding more ablation in patients with persistent AFib would be beneficial. And CAPLA found that there was no benefit to the additional ablation. It was a multi-center trial in Australia, good centers. So it did inform a specific area of electrophysiology, but that's not the important lesson. The important lesson is that everybody believed, because of observational studies, because of single center studies, because of expert opinion, that this extra ablation was something that they should do, and we did it. But yet, when it was tested in a randomized trial, no benefit. And so for me, the lesson from that trial is to test our therapies. When I look at trials, I think the first thing is I always look at the patients that are being studied. Are the patients in this trial representative of the patients we are going to see in practice? So this is always the first step, patients. The second thing I look at in a trial is whether there's good, what we call internal validity. Was there good randomization? Was there good control of bias? Was there not so much loss to follow-up? And so you're looking for good internal validity. Okay, then we look at the results. Were the results clear? Were there good effect sizes? Were they statistically robust? And you know, the results can be negative or positive, but you really like to look at whether they're an important clinical effect size. And then finally, I always look for interpretation. Do the authors spin the results? Are they trying to distract us from the primary outcome and trying to show us something else? So those are the big four characteristics that I look in a trial. I was really struck by the Brian Nosek paper in which he brought together 29 teams of statisticians to analyze one database to ask one question, and they came up with different results that were statistically, one-third statistically significant, two-thirds not. And the point is that by using different analytic methods, they got to different results. And I was shocked by this because most studies always tell us they're going to use one statistical method. And I always wonder myself, what if they used the other 28 kinds of statistical methods, would they find different results? So what I take from that is you always want studies to pre-specify how they're going to analyze the study. You want them to be humble in the way they interpret the results. And another thing that I thought would be very reasonable is to have the source data, like the original data, open for independent review so that other statistical teams can look at the results and see if they come up with similar findings. And I think that good results, solid results, would stand up to independent scrutiny. So for me, this is one of the solutions, and I know that's a provocative solution, but it's one I believe in.